Can you guys hear me okay?
Yeah, we can hear you.
Cool. We'll just give everyone a couple minutes.
There he is.
My baby, found my baby, found my baby.
All right, cool. I guess other people will jump in as time goes on. All right, are you able to see the PowerPoint?
Yes.
Okay, now it should be like full screen, I think, right? Cool. All right. Okay. So, and everyone can hear me okay, right? Yeah, cool. Okay, so basically what we're gonna do is we're gonna go over hip fractures, pelvic fractures, um, and how to do an exam on a patient, how to look at X-rays, how to kind of figure out what it is that you're looking at, clinical decision making, how to diagnose, how to make sure that you have everything ready for the OR. And then I'll go over a couple of things that we're going to go do in the OR, usually when we're treating these things, and then we can kind of, take it from there. If at any point something's not clear, just let me know. And the more questions, the better. Try to keep this to, about 45 minutes or so. And if we run out of time, um, then we'll go from there. So, all right. So first thing we'll go over types of pelvis fractures, types of hip fractures. We'll talk about operative and non-operative treatment, the type of fixation. In hip fractures, we'll talk about, whether or not you're going to do a hemi or a total or hip arthroplasty, and then we'll talk about some OR prep and some techniques. The first thing is a physical exam. When you come up to a patient, a lot of times they'll have a history of a fall. Especially in these older patients, the younger patients, they may have, a more pronounced or a higher energy injury, like, a car accident or a motorcycle accident or a fall from, a fall from height, um, potentially knee against the dashboard during a car accident. There are certain, kind of some indicators that, the hip itself was injured. Hopefully the ER has done some type of preliminary history and a rudimentary exam, so you're going to get a call. Hopefully, there's imaging that's already done, but your indicators of injury in patients that have hip fractures, they when you look at them, the affected leg may be shortened and externally rotated. There's tendernous palpation both in the groin and over the greater trochanter area. Sometimes there are patients that have non-displaced hip fractures, and they actually have symmetric leg lengths, and they may even be able to walk if it's a stable hip fracture, but they'll be talking about pain, along the groin area, going down the thigh, and sometimes even in the knee. So if you have patients that, have both knee pain and pain in their groin, be very suspicious for a hip fracture or something that's going on. They have pain with log roll and axial loading, meaning a log roll is when the patient is lying supine. You place your hands on their leg and you kind of gently internally and externally rotate their leg. And then axial load is exactly what it sounds like. You kind of grab the foot or the tibia and you gently load, the hip. Basically, you're simulating putting weight on it. Um, um, like we talked about, sometimes they may have inability to straight leg raise or move, but those are kind of your indicators that something might be going on with the hip. Just a little bit of what we would call osteology. Um, the This is an X-ray of the. Can you see my cursor, by the way?
Yes, we can.
Okay, but do you see the participants as well, or you only see my cursor, right? You don't see like the list of names or anything, right?
We could see it on the top, but your screen is like the main screen.
Got it. Okay, cool. I just want to make sure that like nothing's being hidden. All right, so this is the osteology of the pelvis. So basically the bones and the landmarks. So this is if you were looking at the outside in. So this is the ilium, this is the ischium, the pubis. Those are the three main inanimate bones that make up each half of the hemipelvis. And then um, those three sections make up what we would kind of call your iliac bone. Okay. And then in between the two iliac bones is your sacrum, right over here. That's the base of your spine. So L5, S1, and that goes all the way down into your coccyx. And then anteriorly, the two ischium and the two pubic bones come together at the pubic symphysis. So believe it or not, there's one bone here, and then a third bone here. And then the junction between these bones, it's all ligaments. So the pubic symphysis is a very, very strong, zone where there are ligaments that hold these two bones together. And then your anterior and posterior um, iliosacral ligaments um, will kind of hold the pelvis together in the posterior ring. These ligaments are incredibly strong. In some cases, are actually stronger than bone, and they're some of the strongest ligaments in the body. So when it comes to the pelvis, you kind of think about the pelvis as a ring, the anterior and posterior ring. We kind of just talked about this, but the anterior and posterior pelvis are basically held together by ligamentous structures. And when the pelvis is stressed, either the ligaments or the bones will fail, depending on the type of injury, and we'll kind of get to that. But the patient, when someone walks, they're the axial skeleton, meaning their spine, and going all the way up from their neck into their head, there's a direct the weight is transmitted through that axial skeleton directly into the pelvis. So the pelvis is the weight bearing area for the upper axial skeleton. So the pelvis can fracture in a number of areas. There can be a rami fracture, which is basically those little rings that you see on the bottom of the pelvis, the two obturator foramen. The rings around those are your ramis. Okay. And that's kind of where the ischium and the ilium meet. So you can have an isolated crack of that. That tends to be like when the elderly patient kind of falls on their behind. They fall down and they sit down very very forcefully, or even not. Sometimes it's just like a ground level fall. You can have a rami fracture. An acetabulum fracture is a fracture of the hip socket. And then depending on, how the acetabulum fractures, there may or may not be a fracture that extends up into the actual pelvis. That's a lot more complicated. That's, more trauma surgery. We don't really need to worry too much about that. Um, you know, Classifying it and recognizing it are what's really important for you guys. The sacrum itself can fracture. You can have an isolated sacrum fracture, or it can be a combination of a rami and a sacrum fracture, and that's usually what we would call a pelvic fracture. That usually happens in either a lateral compression fracture or an anterior posterior compression fracture. And we'll kind of go into that. More often than not, the lower energy fractures are going to be lateral compression fractures. So we'll talk about that because that's really what you're going to see in your consults. Over at Jersey Shore, um, that you're going to see potentially um, more higher energy injuries. So this is kind of the classification of the pelvic fractures. An anterior posterior compression fracture, which is what APC stands for. Think about someone laying on their back and the force going from the front into the back. So like they're crushed by something. Like the graphic but accurate way of thinking about this is like if someone got run over by a car and they were laying on their back. That's kind of how the pelvis would fail. Lateral compression is exactly what it sounds like. It's the compressive force is coming from the side. So it tends to be that people that fall down, like, your elderly patients that fall down on their side, if they don't break their hip, sometimes they land directly on their pelvis, and that lateral force is what, causes the injury. Now, there's different grades. You'll hear us say LC1 or LC2. That just depends on the force that goes through the pelvis, whether or not it just breaks the anterior ring and there's a posterior crunch, or an anterior and complete posterior fracture. So, in a lateral compression type 1 injury, there's an anterior ring fracture and then just a little bit of a crunch on the pelvis, and the fracture is stable. Patient can bear weight after that. In a lateral compression 2 fracture, the fracture is from the anterior ring and then actually goes posteriorly through the bony pelvis. That fracture is not stable, and that patient most of the time will need surgery in the form of a sacroiliac screw or an SI screw. Um, Vertical shear is very, very high energy, and there's a very high mortality. You're probably not going to see that unless you're taking trauma call at Jersey Shore. So this is a CT scan. This is the difference between an LC1 and an LC2 fracture. This is, assuming that you see the anterior rami fractures, you can see over here that there's a little crunch in the pelvis, and it's actually on both sides. But it doesn't extend posteriorly through the ilium. So this is an LC1 fracture, and this patient can bear weight as tolerated with a walker. Whereas on this side over here, you can see that there's a sacral crunch, and then that energy has exited posterior through the posterior elements. This is a fracture that's not stable. So this part of the hemipelvis is dissociated from this part. There's nothing holding it together. Right over here, there's a crack here, but all of these ligaments are intact. Oh, sorry. All of these ligaments are intact. Okay. So the pelvis is actually united this way. So because of that, the pelvis is stable enough to walk on it. But over here, there's a dissociation. So an LC2 fracture, you usually need surgery. An LC1 doesn't. Now, you may have seen a surgeon treat an LC2 fracture non-operatively. It's usually in patients that are very low demand and they're touchdown weight bearing for a while. APC fractures are a little bit different. So usually what happens is that anterior posterior force will cause the pelvis to like kind of split apart. You can see that there's an obvious diastasis here, meaning that there's space between the two bones. And you can also see here in the sacroiliac joint that there's widening, and this is a CT scan of the same type of injury. So in this type of injury, very, very often it's operative. So what would need to happen is we would need to make what's called a fan and steel incision, and we would put a plate across this and bring the pelvis back together. Um, if the pelvis, if it just opens anteriorly, like in the anterior aspect of the posterior elements, if that makes any sense, then usually a plate across here will be okay because these ligaments are still intact, the posterior sacroiliac ligaments, which are the strongest ligaments in the body. If this is all moved, if this is all diastased, then it's a much more complicated injury. Um, So, this is kind of just a treatment summary slide for pelvic fractures. Do a good exam. When a patient has a pelvic fracture, look for other injuries, see what their hemoglobin is, see what their vitals are, because the pelvis can hold a lot of blood. A patient can have a displaced pelvic fracture and they can bleed several liters into their pelvis, and they might not even show any other signs of injury. They look relatively normal, but their body will decompensate very quickly. LC1 fractures, weight bearing is tolerated or protected weight bearing with a walker. Depends on the attending preference. Some people like to be much more cautious with these. LC2s are touchdown weight bearing and potentially operative. APC1, and APC1 is just that means that the anterior ligaments are either sprained or slightly torn. It's very rare to see this. If you're not sure, just call and ask the attending. But APC2 is usually operative, and depending on how wide that pelvis is, they might need some hemodynamic monitoring. So, let me just double check over here. Okay, good. Um, Still able to see my screen?
Yep.
Yeah, cool. Okay. All right. So other type of pelvic fractures, um, LC3, APC3, and vertical shear fractures. Now, just for completeness sake, you know, um, I put this on there because these are technically other types of fractures in the Youngberg and the Young-Burgess classification, but these are really high energy fractures. Um, does anyone know how to put a pelvic binding sheet or a pelvic binder on someone?
I don't think traditionally we've had too many that we've had to do them on.
Yes,
Like you said,
yes.
because of the acuity of it.
Yeah, so a pelvic binder, I'm like, look, I'd like to have like a few workshops with you guys, like splinting and whatnot. But if you're taking trauma call at Jersey Shore, so the thing is, usually our group doesn't cover trauma. We usually have general orthopedic call, so a lot of times, like the higher energy injuries will go to the other group. So those PAs are probably a little bit more versed with, but it's good to know how to do it. So I can show you that when we have some time. But a pelvic binder is a good thing to be able to apply to someone because basically what it does is it closes down the available free space of the pelvis so that it doesn't bleed as much because what kills these patients is internal blood loss. Um, you actually don't even need a binder. You can take a bed sheet and you can very effectively close down, the free space, and it can save someone's life. But if you see a very displaced pelvic fracture, you want to get your attending on the phone. And the other thing to do is probably get IR involved, because they may need to embolize some things, and you have to be ready to activate MTP or transfusion protocol. But this type of injury should not land at Ocean Medical Center. If it does, they're going to need to be transferred. But if it did happen, you would need to put a sheet on them or something to stabilize them, or they would be dead by the time they get to Jersey Shore. So you have to. I'll go over that with you guys eventually to show you how to do it, but just so you've seen it. Um, any questions on pelvic fractures? So far, so good. Yeah. Okay. All right. Acetabulum fractures. Um, so acetabulum fractures are technically part of pelvic fractures, but what you need to know about them is it's a fracture of the hip socket. Um, they're bimodal in age distribution, which basically means that it happens to really young people in high energy situations, and it happens to older people in low energy situations. Um, they tend to happen when there's, some type of force that's applied across the joint, which makes sense. They have an association with hip dislocations. As far as you're going to have a similar physical exam. The leg may be shortened. It's going to be very difficult to have them, bear weight or do range of motion. And sometimes, depending on how the hip socket is broken, the femoral head may be protruded into the pelvis, or they may be very, very unstable and dislocated. In those cases, they may require traction. So this is, an X-ray of what you would, somebody with an acetabulum fracture may look like. So in this situation, this is, uh, a an associated fracture type where it's not simple. Both columns are involved. And you can see over here, when I say both columns, I mean the anterior and posterior column of the acetabulum, but you can see that the joint itself has been disrupted and the femoral head is protruding into the pelvis itself. So this would require potentially traction so that you can bring the hip joint back into alignment, and they don't suffer serious injury. Um, these images over here show how a posterior wall fracture can lead to instability of the femoral head, and the hip joint. So, um, again, at Ocean Medical Center, operative acetabulum fractures are kind of on the more rare side, but you just want to keep your eyes open when you have someone that has a fall. We always look for the hip fracture, like the femoral neck or the intertrochanteric hip fracture, but you have to, you want to make sure that you keep an eye on the acetabulum itself. This is something that a trauma surgeon is probably going to operate on and take care of. Um, this is kind of beyond the scope of this talk, but just in case you wanted to look at it, there are 5 types of elementary fractures and 5 types of associated fractures. The elementary fractured are more simple fracture patterns and usually only involve one column, like the anterior posterior column or anterior posterior wall, except for transverse fractures. And then the associated fractures are more complicated. When these happen, sometimes they're non-operative, like anterior wall, and sometimes anterior column fractures can be treated non-operatively. Very rarely posterior wall fractures can be treated non-operatively, or if they're just minimally displaced or a very elderly patient. Um, Old patients that fall and have acetabulum fractures, they tend to be um, this fracture right over here, anterior column, posterior hemitransverse, or they tend to be like a wedge fracture of the anterior wall. Um, if there's this, displaced fracture or unstable, then there's a number of approaches. There's a number of fixation strategies. That's basically why you do a trauma fellowship. And again, that's usually something that's done at Jersey Shore. I wouldn't recommend anyone do an acetabulum fracture at Ocean Medical Center. It's just, it's specialized equipment. You need some specialized um tables, x-ray, the pelvic sets that they have, the plates, the retractors are all very specific. So that's usually, taken care of at a trauma center. Okay. So we went through pelvic fractures, and a lot of that was more for just completeness sake, so that, you guys have seen it before. The more, bread and butter stuff is going to be over here, the types of hip fractures. So hip fracture meaning, the proximal end of the femur, the femoral head, the femoral neck, and then the proximal intertrochanteric region. Okay, so this is really important. When you see someone that has a hip fracture, you're on call, you get the phone call, and you see, Jane Smith, 85-year-old female, you have a consult for a hip fracture. What you want to make sure is A, that the patient is examined the right way, and B, that you want in your head, you want to start your internal clock. The big thing with hip fractures is, there's a high rate of mortality. We don't really necessarily associate the two because they're not visibly bleeding. They're not hemodynamically unstable usually. They're just in pain. They're elderly, they fell, they broke their hip, they can't walk. But there's a very high rate of mortality because of the sequelae that come from the injury and being immobile. If you don't walk, your ability to regenerate, um, uh, not regenerate, your ability to recuperate, is very compromised. Okay, the longer you can't walk, the longer you have, the longer that you give yourself the chance of developing complications like DVTs, that can lead to pulmonary emboli. You can develop, skin breakdown. A lot of these patients, they're not necessarily healthy to begin with. So when you kind of stop their ability to ambulate, a lot of their other medical issues kind of get exacerbated. So you want to efficiently take care of these patients and get them into the OR as quickly and as safely as possible. So the first thing you need to do is make sure that there's a couple of orders that go in right away. You get the call, make sure that they have a pelvis x-ray, a hip x-ray, and they have a full-length femur x-ray. The reason being, the fixation is going to involve the femur. You want to make sure that there's no segmental fracture. You want to make sure that there's no abnormality of the bone. You want to make sure that the patient, doesn't have a bone lesion that's just distal to where the hemiarthroplasty is going to go. Um, if let's say we're doing, a long nail, um, and they have a very, very narrow canal, that's also something like there's a lot of things that the attending is going to want to know. So always get a pelvis hip and full length femur. Um, Also, sometimes, a lot of times the patient gets admitted to medicine, and we kind of rely on medicine to put in some of the preoperative orders. But all the patients that are going to the operating room should get a CBC, a BMP. They should get coags, so PT, PTT, INR, a type and screen, an EKG, and a chest X-ray. That is, every patient that goes to the OR is going to need that. So if you throw it in, you don't have to wait for the first year resident on internal medicine to forget about it, and then never put it in. And then it's 1 or 2 o'clock and they're not cleared and all that stuff. And the second thing is a medical consult and clearance should happen like right away. Um, as soon as you see them, make sure that that's in. The ER orders it sometimes, but this should be on your checklist. Make sure all these things happen because all of this stuff needs to happen for them to go to the OR, and the faster that it's in place, when the time comes when the on-call attending is like, so, becomes free at 3 or 4 o'clock, whenever it is, they're ready to go. And then, you just touch base with the attending. I would touch base with them first thing in the morning because then you can tell them, what's on the docket. But also it will give them an idea of, okay, like I'm gonna, I have this hip fracture. I want this vendor. I want this table, but get everything going early. All right, so femoral head fractures. Um, Femoral head fractures are pretty rare and they tend to be pretty high energy. Um, they're almost always operative. They tend to be associated with hip dislocations or something called the Pipkin classification, but this is kind of the classification. If you see a femoral head fracture, again, this is, kind of a trauma case. If it happens in a young person, we try to fix it and piece it together to preserve their hip. If it's an elderly patient, it's usually, a hip arthroplasty. Okay, femoral neck fractures. So the way to think about femoral neck fractures is whether or not the hip fracture is displaced and whether or not it's stable. Um, we have something called the Garding classification, which I'll show you, which is pretty good with this. But that's the basic way of thinking about it. If the ice cream has fallen off the ice cream cone, then it's displaced. If the ice cream is going to fall off the ice cream cone, then it's unstable. Um, and then there's other types of descriptions like subcapital, transcervical, basicervical, valgus impacted. Those are all radiological terms, but and some of them kind of um, they kind of indicate things like a valgus impacted femoral neck usually is stable, but it doesn't always have to be that way. Um, other than are just anatomical terms like subcapital, like that's where the fracture is, but it's either displaced or not displaced and stable or unstable. Um, Also a note, if there's a patient that comes in and they have pain and inability to bear weight, and they may or may not have a history of trauma with negative x-rays and you're worried about a fracture, the imaging modality is a MRI without contrast. A lot of times the ER will order a CT scan or they'll push you to get a CT scan because a CT scan takes 5 minutes, whereas an MRI is a lot harder to get. But if you have a patient that has a negative x-ray, but you're concerned about a femoral neck fracture, then the answer is an MRI without contrast. Whether or not this is done in the ER or it's done as an outpatient is kind of a discussion to have with the attending and the ER, but you want to make sure that the MRI is done because if there's no visible, fracture on X-ray, they can get a CT scan and that can be negative, but they can still have a positive stress fracture. Okay, so this is the garden classification. But basically what you need to know is this fracture over here is a garden 1. And this is a stable fracture. Okay, it's minimally displaced and it's stable, meaning the patient can actually bear weight on it as an intact posterior medial cortex. Whereas, the progression is non-displaced but not stable. So like it's a complete fracture and the the it's a complete fracture, but it hasn't moved. But that's not a stable fracture. Over here, it's a not stable but not completely displaced fracture. And then you have completely displaced and obviously unstable. So this one is potentially, amenable to fixation. This could be amenable to fixation. This is an arthroplasty and this is an arthroplasty. Okay, that's kind of what we just said. The only thing is in some femoral neck fractures, there's something called a basicervical femoral neck fracture. The blood supply to the femoral neck is very tenuous, and it's composed of the circumflex arteries. And basically, these arteries run intracapsularly, anteriorly and posteriorly, and they're very intimate with the bone. So when the bone breaks, the arteries tear. Okay. And if you've ever done an anterior hip with me, you know kind of how close those arteries are to the actual capsule, and you know how like intimate they are with them. So usually when there's a fracture, those arteries kind of get torn up. If the fracture is more down here, it's extracapsular, and this kind of behaves more like an intertrochanteric fracture, and it can be nailed. So you may hear that term, and it may not be like a true intertrochanteric fracture where the fracture is right over here. It may be a little bit, maybe a little bit more proximal, but these fractures can actually be nailed and they tend to heal. Okay, so types of treatment. Non-operative is very rare. Okay, these are patients that are really sick. There's a strong contraindication to surgery. Hospice, palliative care. There's always these unique situations, but it's very rare. If the fracture is stable or non-displaced, it may be amenable to fixation, but yeah, there's a risk of avascular necrosis and fixation failure. So that's a attending decision. If it's displaced, it's almost always going to be a total or a hemiarthroplasty, because that femoral head is not going to heal, and chances of success with fixation are very minimal. So we tend to go right to arthroplasty. Okay, so cannulated screw fixation or plate and screw construct. These are the two main ways that we fix these non-displaced or these stable head fractures. If you do cannulated screws, it's most likely 3 screws in an inverted triangle. The posterior and inferior screws are most important. And then if you do a plate and screw construct like this, the Synthes femoral neck system is the system that I like to use. It's basically, a screw and a side plate with one distal bicortical interlocking screw. DHS you can do, but it's much more common for intertrochanteric fractures. Types of fixation. Other than that, there's hemiarthroplasty or total hip replacement. It's a very common question, and it really just comes down to asking the attending what they want to do. But a hemiarthroplasty tends to be reserved for more elderly patients, lower demand because it's metal on bone, whereas a total hip replacement is a complete replacement. They do have better outcome scores. There's a higher risk of dislocation. Usually in our practice, I think that's usually reserved for younger, more active patients that fracture their hips in their 60s and 70s, maybe even sometimes early 80s. And then your later 80s, early 90s tend to get hemiarthroplasties. And then cement or no cement, I think in our practice, cementing is for really poor bone. And I've cemented a fair number of hemis. I know people that have worked with me will do it. There's no right or wrong answer. Cementing has its risks. There's a rate of pulmonary complications. You can get a, you can get a fat emboli while you cement, and there's risks. But when you don't cement, you have run the risk of periprosthetic fracture. So it's kind of up to the attending and how they want to do it. But those are the two different types of fixation. So total or hemi, how active is the patient? This is something you can figure out. Like, if there's someone that walks around and they walk 3-4 miles a day, they might be a total candidate. What's their level of activity? If you're talking to them and it turns out that they're a Parkinson's patient or they have, advanced dementia, then a hemiarthroplasty might be a better move because there's a lower risk of dislocation. And then also surgeon preference, if there's an arthroplasty surgeon that's on call, they may feel more comfortable doing a total hip on someone that's like kind of in between, whereas someone that doesn't do a lot of totals may do a hemiarthroplasty and the patient will do just fine. So it's kind of it's also surgeon preference. Okay, so OR setup. So tips and tricks. Usually the patient's going to be supine on a fracture table or a specialized table. I like to use the HANA table, but everyone has a different preference. Um, when you're draping, you want the surgical, like the things that you need to be able to see are the iliac wing and the greater trochanter. Um, I like to keep the surgical arm away from the surgical field. The arm can be out, but I think it tends to be that it's a little bit hard to kind of wedge yourself in there, especially if the patient's very small. So I like to take the surgical arm and bring it up and over the body and tape it out of the way. Also, you have to make sure that your draping allows for C-arm to maneuver between an AP and one lateral. So you have to make sure that you have either C-armor or I use a shower curtain and I kind of I kind of place the shower curtain with weights on the bottom so that the drape doesn't come all the way out. The non-surgical leg should be placed in either a scissor formation, which is like this, or it needs to be placed up into a well leg holder. My preference is scissor formation. It doesn't matter. It just as long as it's safe. Very important though, you have to make sure that the sliding mechanism is unlocked when you put the patient on the trap fracture table. If one leg is locked and one leg isn't, when you're maneuvering the leg, you will break the other leg. Okay, because it's very, very powerful. When you maneuver, so when you extend this leg, let's say this is a patient that has no broken hip. If you extend one leg and this leg is locked, what will happen is it will place an incredible amount of stress on both hips. If both legs are unlocked, this leg will extend and then this leg will actually shorten because the pelvis will be pulled down. But if, say, this leg was locked over here and you extended this leg, this hip would fracture and dislocate and potentially distract. So you have to be really, really careful. So, I've seen iatrogenic injuries from these. Also, when you put the leg up in the well holder, you have to be very careful, especially in like these very elderly patients. You can flex and internally, externally rotate the leg. I've seen distal femur fractures from like manipulating the leg the wrong way. So you gotta be very, very careful. Okay. So when you're doing an FNS or a sliding hip screw, the step that you're gonna see, we make an incision and exposure usually laterally. We go down through skin, subcutaneous tissue, we get down to bone. And then usually there's an angle, a fixed angle guide that you put on. The fixed angle guide, the attending will put on, they may have you hold the guide or they may actually hold the guide and have you shoot the wire. That guide makes sure that the wire goes in at the correct angle that mimics the plate angle. So, for an FNS, it's either 127.5 or 125 degrees. I have to double check. But it's important that that guide is on bone, and then that wire, you want that wire to go in a center position. So you want the wire to be just at the tip of the femoral head, and you want it to make sure that from its path, it ends up in the center of the femoral head. And then on the lateral, it wants to be going straight down the middle over here. So that's called the center position. Okay. That's extremely important in an FNS, a DHS, and an intramedullary nail. Once that wire is placed, you're going to measure how long the wire is, because that's going to be the same distance, the same length of your blade or your screw. And then after that, you're going to ream to make room for that blade or screw. And then you're going to place your construct. And then you're going to fix it distally, usually with a bicortical screw. So that's an FNS. DHS is honestly very, very similar. This is your fixed angle guide. The wire goes up. you measure, and then you put your triple reamer in, the plate goes in, and then you put your distal fixation. Okay. Arthroplasty, for your displaced femoral neck fractures, there's a couple of different approaches: posterior based, lateral based, and anterior based. Um, your posterior approach is basically it's a modified Coker-Langenbeck. Your lateral based, those are your direct lateral approaches, your anterolateral approaches, and then your direct anterior approaches, your anterior based approaches. Each approach has advantages and disadvantages. No one is right or wrong. Most of the time, your lateral and posterior approaches, the patient's going to be lateral, either on a beanbag or with hip positioners. And an anterior hip, they're going to be supine. They may be on a fracture or specialized table, or you can actually do it on a regular OR table. It just depends on the attending preference. So, usually you kind of know, like I do anterior hips, Roderick's and Bogdan do posterior. I would say almost all of our attendings that are non-arthroplasty surgeons, almost all of them do a posterior hemi, except I believe Dr. Nakashian does an anterolateral hip. But for the most part, you kind of usually know, what attending does what. So, anterior, posterior, and laterally based advantages. Just real quick, posterior, because, a patient may ask you, a posterior hip, the disadvantage is it does have stability issues. A posterior hip has the higher rate of dislocation out the back. When a patient's using the commode or when they, bend down and internally rotate their leg, they can come out. Usually for hemiarthroplasties, it's pretty stable. Total hips are a different story. The advantage to a posterior approach is it's very extensile. So it's a workhorse incision, especially in complex fractures. If there's like, an associated acetabulum fracture, those like it has a lot. It's a very useful approach. Anterior approach, it tends to be very stable. It's a very low rate of dislocation. They tend to have some wound issues every once in a while, and also there's a higher rate of periprosthetic fracture. Delivering the femur, and the stress that it puts on the femur it can be a little bit tough. So your higher rate of periprosthetic fracture. Your laterally based approaches, they tend to be very stable. Usually the abductor musculature is split, so sometimes there's a risk of nerve injury, and sometimes these patients can have a little bit of an abductor limp, and they also sometimes they can develop heterotopic ossification. Okay, so arthroplasty principles, when you're in that case, the attending is going to expose. They're going to remove the femoral head. In a total hip arthroplasty, they're going to expose the acetabulum, so they're going to replace retractors around it, cut out the labrum, get a good exposure, and then you're going to ream. So reaming is using that circular saw. You take away the cartilage, and you basically get an interference fit, between your anterior and posterior columns. Once they've sized it, they're going to impact the cup with or without screws, and they're going to place a liner. After that, you're going to expose the femur. This is done differently in an anterior, posterior, and lateral approach. You're going to broach. When you're done broaching, you're going to place the stem, which is either a press fit or a cemented stem, and then you're going to place the head, and then you're going to reduce it. So this is kind of just a quick, schematic of, what an acetabulum looks like when you ream it. Okay, expose, acet ream. You place the cup. You can place, screws potentially and put the liner in. And then if you're doing a dual mobility, the liner will look just a little bit different. And then as far as the femoral preparation, you've seen if you've done arthroplasty, there's steps, getting the canal exposure using a box osteotome. And we sequentially broach up to, the correct size stem. We trial, we make sure everything is, stable. And then, you put your final implant in. Okay, intertrochanteric hip fractures. They're either displaced or non-displaced, and they're stable or unstable. So what does stable or unstable mean? It basically means that, if you put, if there's an intact posterior medial cortex, then your fracture is stable by definition. if the posterior medial cortex is comminuted, then it's unstable. What does that mean? A stable fracture can be fixed with a DHS, a screw and side plate. An unstable fracture can't. It needs an intramedullary nail. Okay. Um, Obviously the treatment's operative. You can either use a screw and side plate or a nail. The steps, they're very similar actually, as far as fixation to your sliding hip screw. You want to place the patient on a fracture table. The attending will reduce the fracture under fluoroscopy. Okay. Then they'll usually lock it. You'll prep and drape. You'll make an incision and put a guide wire in at the tip of the troch. That will be advanced. You'll do an entry reamer to open up the fracture or open up the femoral canal. If you're going to do a long nail, you'll put the guide wire in and then you'll measure and then you'll start reaming to get your femoral size. You're going to insert your nail. You'll put your cephalomedullary guide wire. You'll get your distal fixation, and then you have to make sure before you leave, you make sure that you lock the set screw. That's the attending's job, but you'll look like a superstar if you ask them, did you do this? Okay, so I mentioned putting the cephalomedullary pin in the correct position, a center position. You'll hear some of us say tip apex distance. One of the big complications of a nail is when this screw cuts out, meaning that it comes out of the femoral head and goes up into the hip socket, the acetabulum. What you want to make sure is that when we place this screw, the distance between the tip of the head and the tip of the screw on the APM lateral is less than 25 millimeters. A center position is ideal, but as far as the principles of fixation, a lower pin is better than a higher pin, and a posterior pin is better than an anterior pin. Just thoughts. And then long or short now, like a lot of times, you'll ask us like, we want to go long or short. For me, if the fracture extends below the lesser trochanter, I tend to go long. If it's just a simple fracture, I tend to go short. Um, with long nails, you have to just make sure though that you don't perforate the cortex anteriorly, and then you also have to make sure that you have everything you need to ream. Okay, so just some cases. So this is a patient with a MRI positive, X-ray negative femoral neck fracture that was treated with an FNS. Okay, this is her post-ops. She actually wound up doing really well. This is a patient that had a fall that had a femoral neck fracture and had a hemiarthroplasty. This is a patient that was 68 that had a femoral neck fracture. And when you look at it, you might think that that's non-displaced, but when the CT scan was obtained, you can see that there's angulation and an apex anterior angulation of more than 20 degrees of this femoral head. So we kind of know from a couple of our studies that this would not heal probably well. So I did a total hip arthroplasty on this patient because they were 68, had pretty good bone stock and was fairly healthy. This is a patient with an unstable intertrochanteric fracture. I know that because the lesser trochanter is off, so the posterior medial cortex is violated. So this is an intramedullary nail. That's a Smith and Nephew Intertan. And then this is another 78-year-old female that had an intertrochanteric fracture. This was a little bit more likely. We would call this a stable fracture because the posterior medial cortex is intact. This was also treated with an intramedullary nail. So I think that's pretty much it. Um, Hopefully, that helped a little bit. Do you guys have any questions?
Recorded?
Did I record it?
Yeah.
Yeah, I recorded everything.
All right, cool.
All right. Okay, cool. So hopefully this was like somewhat informative. If you guys have any questions, just, shoot me a text or call me or whatnot. Um, but hopefully I answered some questions and kind of, we'll get everyone kind of like to a baseline of knowledge. If you have, there's a couple of good resources out there. I have a couple of them actually saved on my computer as far as like, hip fracture management and stuff. But if you have questions, just ask.
Thank you.
Cool,
Thank
guys.
you.
Yeah, for sure. All right.
Thank you.
I'll see you guys around. Take care.